I am Dr. D. Ravindranath, Professor and Head, Department of the Periodontics and Implantology, Sibar Institute of Dental Sciences. Today, I am going to explain the bone grafting techniques for the undergraduate students, and I am giving the basic concepts of the bone grafting procedures and various bone defects. What is the definition of the bone graft? Bone grafts are the materials to mineralize and augment the bony defects. And what are the indications of the bone grafting procedures? The indications are the main is the intra-osseous defects, and to give the support to the tooth structure, and to whenever there is a furcation defects are there, we are going to place the bone graft materials. Then what is the rationale for this bone graft procedure? The rationale for the bone graft is that to improve the clinical attachment level and enhance the regeneration of the bone. And then come to the what are the advantages of this bone graft procedures. The advantages are to reduce the pocket depth and to fill the bony defect and to treat any furcation defects, furcation involvement. You can treat that. You can use the bone graft procedures. And what are the diagnosis? How you diagnose this bony defects first? The bony defects are diagnosed with clinically and radiographically. Clinically, the bony defects diagnosed by the procedure is called the sounding the bone or transgingival probing. The sounding the bone means that we anesthetize that area and we'll insert the probe deeply into the crust of the bone, and we feel the crust margins, and you can feel the bony defects and bony plates around the teeth and the root surface. This is the technique to clinically we can assess the bony defects. Radiographically, there are different procedures to assess the bony defects. One is the IOPA and OPG and CBCT. And IOPA and OPG are the two-dimensional views, and we cannot assess the perfect bony defects. And CBCT is that three-dimensional view. We can assess all the dimensions of the bony defect, and this is an accurate method to assess the bony defect. Once we diagnose the bony defect, we have to treat the bony defects. And before going to treat the bony defects, what are the different types of the bony defects in periodontics? One is that intra-osseous defects, and another one is the furcation involvements and osseous creators. The intra-osseous defects are the main is the angular bone defects is there. The angular bone defects are mainly three types. One is that one wall defect, and two wall defect, and three wall defect. The one wall defect means that only one bony wall is present around the root surface. The one wall means only one wall is present and three walls are missing. This is also called as the hemiseptum. The next one is that two wall defect means that two walls are absent and two walls are present. And next is a three wall defect means only one wall is absent, three walls are present. If you see the prognosis of this bony defects, the two wall defects and three wall defects are they having the good prognosis. The three wall defect is having three walls present and one wall only, one wall is missing. The two wall defect means two walls are present, two walls are missing. So the prognosis is good for the three wall defect and compared to the one wall and two wall defects. These are the ideal cases to place the bony defects. The other bony defect is the furcation involvement is the grade 2 furcation involvement and grade 3 furcation involvements. These are the grafts, these are the defects we place the bone grafts. And we diagnose it properly and we select the cases for the bone grafting procedures. And then you come to the what are the different types of the bone graft materials we use for the bone grafting techniques. And they are classified, these bone grafts are the, one is the human based and non-human based. The human based bone grafts are the autogenic bone grafts, allogenic bone grafts. Autogenic bone grafts are again, they are classified into intraoral and extraoral bone grafts. Autogenic bone grafts means that we are taking the bone graft, obtaining the bone graft from the same person. Who needs the bone graft? The same person we are going to take the bone graft. They are classified into intraoral and extraoral. The intraorally we obtain the bone graft from the symphysis area and we can take the bone graft from the maxillary tuberosity area. And we can take the any extracted sockets, we can take the bone graft. And extraoral bone grafts we can take from the ribs, we can take from the iliac crust grafts, you can use to take the bone grafts extraorally. The autogenic bone grafts are the disadvantage with its autogenic bone grafts are the less availability. The quantity of the bone is very less. Okay, this is one of the major disadvantages with the autogenic bone grafts. The advantage of this autogenic bone grafts is there is no antigenicity will be there, no graft rejection will be there for the autogenic bone grafts. Next one is the next human bone grafts are the allografts. Allografts are the bone grafts obtained from the same species but different person. These are the allogenic bone grafts. These allogenic bone grafts are classified into two types. One is the FDBA and second one is the DFDBA. FDBA means freeze-dried bone allogenic graft and DFDBA means decalcified or demineralized freeze-dried bone allogenic graft. The DFDBA is that grafts are the best compared to the FDBA because the DFDBA, once we decalcified the bone graft, there is a exposure of the bone morphogenic proteins, BMP. These morphogenic proteins are the directly induce the bone. But the FDBA is it will take some time for the biological decalcification and exposing of the bone morphogenic proteins and then it will induce the bone. Okay, and the next one is that non-human bone grafts are the two types. One is the xenografts and alloplast. The xenografts are the grafts, there is a different species. Okay, there is a different species, especially the example is the bovine bone grafts. Okay, bovine bone grafts and coral bone grafts they use for the xenografts. And alloplasts are the synthetic bone grafts. And example hydroxyapatite and tricalcium phosphate, beta tricalcium phosphate bone grafts they use as a alloplast. Okay, these are the different bone grafts used for the different bony defects. And we have to select this bone graft for the different bony defects and availability of the bone graft, and we have to check the bone graft availability and we check the amount of the bone graft we need and we assess the bony defect, then we select the bone graft and we have to place the bone graft. And what is the mechanism of this bone regeneration? There is a different bone grafts act as a different having a different mechanism. If you take the autogenous bone grafts, it forms by the bone graft by the osteogenesis. Osteogenesis means directly it will form the bone. If you place the autogenic bone graft, it will directly form the bone. This is the best bone grafts forever compared to the other grafts. But the disadvantage is the quantity of the bone. Quantity, we get the obtain very less quantity of the bone. The next one is that osteoconductive bone grafts. Osteoconductive means these bone grafts act as a physically, and it will give the support to the all the cells which form the bone and blood vessels. Especially the example for this osteoconductive materials are the osteoplasts. And osteoplast is synthetic grafts. All the synthetic grafts like hydroxyapatite and beta tricalcium phosphate grafts, these are act as a osteoconductive. It acts as a framework or scaffold and it gives support to the all the blood vessels and cells which form the bone. Okay, next type of this mechanism is the osteoinductive. Osteoinductive means these bone grafts are the induce the induce the surrounding cells to form the convert it into the osteogenic cells and form the bone. The example for this osteoinductive materials are the allografts. These, especially these allografts, the DFDBA, decalcified bone allogenic grafts, are the act as a osteoconductive because this exposure of the BMPs, the bone morphogenic proteins, will directly induce the bone and act as a osteoinductive material. And FDBA grafts, freeze-dried bone allogenic grafts, initially these act as a osteoconductive materials. Once the biological decalcification takes place, there is a bone morphogenic proteins will expose and later it act as a osteoinductive materials. So this is the mechanism of the bone formation of the different bone grafting materials. And how long we wait to get the bone material in the bony defect area. Once we place the bone graft material, and the autogenic bone grafts will form bone very immediately, that it will take less time to form the bone. The osteoinductive materials, it will take the 3 to 6 months time, and osteoconductive materials, it acts as a framework only, and it will take 9 months to 12 months time to take the bone grafting of bone, fill the bone defects. Okay, these are some of the basic concepts of the bone graft materials and bony defects and mechanism of the bone formation and regeneration techniques. Thank you. As for the theoretical knowledge, the autogenic bone grafts are the best bone grafts, and these are the bone grafts we obtain from the same person, and intraorally and extraorally. The intraoral bone grafts we take especially from the symphysis and maxillary tuberosity area, or if any extracted sockets, you can take the bony spicules and you can crush the bone and will place the bone graft in the bony defects area. And there is a different types of the autogenic bone grafts intraoral. There is a bone blend will be there, and these are the bone blend. We can take the bone graft and we can triturate and we will mix with the blood and we will place the bone graft and bone defect area. And another bone grafts are these are the things. This is the DFDBA, allogenic bone graft. Bone grafts. We obtain this bone graft from the bone banks, and this is the after the, suppose if not autografts are not available, but autografts quantity is very less, we can mix the autograft with the allogenic graft. There is a lot of research is giving the good result with the autografts combined with the allogenic grafts when we need the sufficient quantity of the bone graft. So these allogenic grafts we can use for the alternate for the autografts. These are the allogenic grafts, are the grafts we taken from the same species from the different person, and they store the grafts in the bone banks, and we can obtain the graft from the bone banks and you can use for the to fill the bony defects. These allogenic bone grafts. The next one is that xenografts. These are the xenografts. We can use. These are the they take the graft from the different species. Okay, especially the bovine grafts. Okay, alternate. Suppose the allografts are not available, we can use the xenografts. We can use the xenografts also. These are the grafts of the alloplasts and synthetic bone grafts. We can use that hydroxy apatite crystals, and we can use this beta tricalcium phosphate, and a combination of this hydroxyapatite and beta tricalcium phosphate also we can use. And recently the research is going on the eggshell graft also. They crush the eggshell and they use the eggshell for as a graft material for the bony defect to fill the bony defects. And also you can use that dentin also, the tooth structure dentin or enamel. We can mill the dentin and we can use as a graft for the bone fills. These are the different some of the synthetic grafts we are using to fill the bony defects. Just we take the graft material and we keep it in the dampened dish. We keep it in the dampened dish and just to mix with the saline or blood. The best one is the blood, or you can use the saline. Make 1-2 drops of the saline and you mix the graft with the bone carrier. Okay, and we mix the graft with the bone carrier and mix nicely with the saline or blood. Okay, then you place the, usually I am showing this is the 2-wall defect. These are the defects are the ideal for the bony graft techniques. 3-wall defect. The 3-wall defect is the only 1 wall is absent and 3 walls are present. These are the ideal for the bony defects. Is also called an intra-osseous defect, and these are the defects you can use for the bony grafting techniques. I mix the bone graft with the saline and I place the graft with the bone carrier, and we place the graft here, and we place the graft here, and once we place the graft, we place the graft in the defect area, and then we use the condenser, bone condenser. Then you condense the bone into the defect. We condense the bone into the defect, and we place the graft until the crust of the bone. Then you condense it nicely, and the graft should be fill all the bony defect. The graft should be fill all the bony defect. Okay, and this is the technique we use to place the bone grafting technique. And whenever we are going to place the bone graft, just you raise the, wherever you are going to place the bone graft, just you raise the full thickness flap or mucoperiosteal flap. You have to expose the bone nicely, and you have to curate that area. Any granulation tissue is there, you curate that area nicely and remove all the granulation tissue, and you have to expose the bone defect nicely. Then you isolate that area, then you mix the bone graft with saline or blood, and you place the bone graft into the defect and condense the bone graft nicely, and you place the bone graft up to the crust of the bone. Then if you need to retain the bone graft, you can cover the bone graft with the membrane. Okay, GTR, guided tissue membrane, and there is different membranes are there to cover that bone graft. You can place the membrane nicely over the bone graft, and you close the flap and suture it nicely, and then you send the patient. And if you want to confirm whether the bone graft is covering all the bony defect or not, post-operatively we take the radiograph and we can check whether the bone graft is nicely condensed or nicely cover the bony defect or not, we can check with the radiograph. Especially the bone grafts, the DFDBA is we cannot check with the post-operative immediately because of decalcification. We cannot identify in the radiographs. But FDBA grafts or any alloplasts, we can check the bone grafts after the immediately after post-operative with the radiographic techniques. Okay, this is the technique we can use to place the bone graft in the bony defect areas. Thank you.